Well, like everyone, I want to thank the Foundation for sponsoring this really incredibly interesting meeting. And it may sound strange for a person from a cancer background to be talking about or listening to talks about the brain and brain function and brain development, but I found it fascinating. And as neurons connect, so do talks. And so it's been a very interesting meeting for me. Thank you so much to all the speakers, and also to Tom and to Kathy for encouraging our work. Okay, so we've been concerned with the problem of treating cancer in Botswana. And I'll provide you with a little background. The geopolitical setting: this is a stable democracy located north of South Africa, between two other countries, Namibia and Mozambique, in the sub-Saharan region. It's been experiencing a serious HIV epidemic for the last 20 years. About a quarter of its adult population is HIV positive. They have a very good, a robust HIV treatment program ongoing, largely financed by the U.S. government, but also by foundations, including the Clinton Foundation, which has been involved in multiple areas. And so that has actually come under surprising control in terms of patients with HIV positivity living a long time. However, another problem has arisen, and that is that the cancer mortality in this population is rising, and it presents a huge problem to a country which has limited resources. Just to put it in context, 2/3 of the cancer in this world occurs in countries of low and middle income. And as the populations age, as the standard of living in these countries improves, we're certain to see that to continue. And many of these countries are totally unprepared to treat cancer or to even diagnose cancer. For example, we have countries in sub-Saharan Africa of 30-40 million people where there is no functioning radiation therapy, and very, very few people trained in medical oncology. So our challenge was to address the problem of lymphomas. Why lymphomas? They're associated with HIV. About 3/4 of the lymphoma cases in Botswana are found in HIV-positive patients. And many of the facts about lymphomas to us were very uncertain at the time we began this project. What is the actual incidence? What's the outcome of treatment for these patients? What are the subtypes that are seen? We knew that in the U.S. that Burkitt's lymphoma, a type of lymphoma associated with EBV, is commonly seen in HIV-positive patients, but we had very little information about what these people were dealing with in sub-Saharan Africa. And this seemed to be a very good setting to study the problem, because it's a relatively smaller population. It has the beginnings of a cancer registry. It has 2 large tertiary care centers where most of the patients are referred. And it has in place resources that we didn't find in other countries, specifically radiation therapy and a hospital with somewhat sophisticated specialty treatment in certain areas, particularly in pathology. So we decided to undertake a study, and fortunately the foundation was willing to support it. And so the investigators in the study are shown here. It's done through this Botswana-Harvard partnership, which was established for AIDS treatment. And Scott Dryden has been a very important collaborator and coordinator for this. 3 of us are medical oncologists. We're shown here, all from the Mass General. Jeremy Abramson's a specialist in lymphoma. I've been the sort of project supervisor, and then we've had a person on site from Mass General, Elizabeth Bigger, a medical oncologist. 2 pathologists have been key in this, and one is Elias Selhani, who's a lymphoma team leader at Mass General in pathology, and had, by coincidence, been raised in Kenya, an Indian family that migrated to Kenya and then came to the United States, and so she was quite interested personally. And then Alphonse Kayembe, who is the pathologist that directs the National Health Laboratories in Gaborone, who was quite interested in seeing confirmation of the diagnoses that he was making on site. So these were the three aims of the project. One was to establish the demography of lymphoma incidence and outcomes. The second was to detail the evaluation of these cases using Mass General Pathology in collaboration with the pathology labs in Gaborone. And third was to implement lymphoma subtyping so that we got a very well-defined picture of the kinds of lymphomas that we were seeing using immunohistochemistry, cytopathology, flow cytometry, and bone marrow evaluation, all of which were not in place at the time we started. So what are the demographics? Well, 60% of the cancers in Botswana arise in HIV-positive patients, and 44%, or nearly half, are clearly AIDS-related cancers. That is, cancers that are known to be associated with HIV positivity. Kaposi sarcoma is the most common. It's a skin cancer. Lymphomas are the third most common. Cervical cancer happens to be an overwhelming problem there. It's HPV-caused cancer. And then finally, squamous carcinomas in various sites. Now, all four of these are known to be associated with viral causes. So the thinking is that the presence of HIV suppresses the immune response to these viruses and allows the development of cancers. So here are some of the basic facts we found. The survival of these patients is not optimal. In the first chart on the right in this slide, you see the rapid fall off and an average survival of about 1 to 2 years for these patients. In the U.S., as you can see in the lower curve, the same population of patients matched for type of cancer would be much greater. It's probably closer to 80–85%, and many of these patients are cured. So there's clearly a deficit in recognition and treatment of the disease, early recognition and treatment. As far as comparing within the lymphoma population in Botswana, you see on these slides that the survival of patients with aggressive forms of the disease is lower, as we would expect in the more aggressive, less aggressive types. Let's see, that's shown on the right slide. And on the left slide, you see something that's actually quite interesting, and that is that there's some but minimal difference in survival between the HIV positive and HIV negative cases, and that was somewhat unexpected. We thought that the HIV positive patients would probably be doing less well. It turns out that they're probably getting, the disease is being recognized in these patients earlier because they're under surveillance because of their HIV positivity. Okay, now as far as the subtyping, our pathologists collaborated, and this 70 specimens were sent to the MGH from Gaborone, and then there was a lot of travel back and forth to coordinate reading of the specimens. As far as subtyping of lymphomas, in the HIV patients, we generally see a more aggressive disease. We tend to see a diffuse large cell lymphoma as the common type in the United States. We see a fair number of Burkitt's lymphoma, which is an EBV-driven disease, which is almost akin to acute leukemia, very rapidly progressive but highly curable with current therapies. And then we see a subset of patients with Hodgkin's disease. In the U.S., it's in general quite a smaller subset than the lymphomas. In HIV negative patients, they're in general split between the large cell types and the follicular or indolent types. Hodgkin's tends to be a little more common in HIV negative patients relative to the HIV positive ones, and Burkitt's is relatively rare in HIV negative patients. And then at times, chronic lymphocytic leukemia with a lot of lymph node enlargement can be potentially confused with non-Hodgkin's lymphomas. And this was one of the objects of our study, how many of these patients actually had small cell lymphomas or CLL. So here's a summary of what we found in terms of the lymphoma classification, the AIM-2 of this study. We reviewed 70 cases. We found a surprising incidence of Hodgkin's disease among these cases, almost a third of their patients. And in fact, there was an overdiagnosis of Hodgkin's disease in 5 additional patients. And that's one of the issues, recognition of Hodgkin's, because it requires somewhat different treatment, significantly different treatment than the non-Hodgkin's lymphomas. About 2/3 were non-Hodgkin's lymphomas, and then there were 3 other cases shown here which were difficult to classify given our current availability of stains and cytometry. So among the aggressive non-Hodgkin's lymphomas, 37 of them were really patients that required very aggressive treatment if it were available. Most of these were large cell lymphomas, diffuse large B-cell lymphomas. 3 or 5 of them were plasmablastic, which is an unusual but very aggressive form of disease. All of these were EBV positive. Burkitt's was relatively uncommon. This was unexpected because Burkitt's is a very common form of lymphoma in Uganda and some of the neighboring countries, but for some reason, and we're not quite sure, it was relatively uncommon in our Botswana population. And then a smattering of other cases, one of mantle cell lymphoma. By the way, the pathology of each of these is shown here, so you can see the somewhat different pathology of each of the different kinds of aggressive disease. And Burkitt's is shown on the lower right. It's a very homogeneous looking smaller cell population. There were some cases of indolent lymphoma. This is unfortunately misspelled here, but indolent B-cell lymphomas are common in the U.S. And some of these are really akin, the small cell lymphomas are very much akin to chronic lymphocytic leukemia in the United States. 2 patients with low-grade follicular lymphomas, which are very common in the U.S., but very uncommon there. And then some T-cell lymphomas, which really are quite different than the B-cell lymphomas. And in general, carry a different prognosis, and in the U.S. would require some differences in treatment. These were the more indolent cases. And their pathology is shown here just for examples. Hodgkin's, as I mentioned, 20 cases. In fact, they had diagnosed 25 of these as being Hodgkin's disease, and 5 of them probably were not. Our pathologist did detailed studies on the slides and showed that they were aggressive non-Hodgkin's lymphomas, which require as I mentioned, a different sort of treatment. Some of these were EBV positive, 83% in this case. That's actually a higher percentage in the United States. And all of them had been, the 20 cases, been correctly diagnosed. As I mentioned, 5 others were called Hodgkin's, but not. So one of the objectives here was to also look at what was needed to improve the care of these patients. And there are a number of factors that came up. One was training in pathology, which prompted visits to the United States by their residents, their pathology residents. Second was implementation of more detailed evaluation of the cases by immunohistochemistry and flow. And this is ongoing now through the Botswana-Harvard partnership at a laboratory that's been established there and has been long-standing for CD4 cell enumeration, but they can adapt it to doing this. Training of medical staff in lymphoma is a big issue. There are no trained medical oncologists, specifically medical oncologists there. The only one was our resident. One of their faculty is now at MGH for 3 months and will go to South Africa for further training, and that should help. But you have to realize this is a country of 2.5 million people, really, and having no medical oncologist or well-trained medical oncologist is a real disadvantage. We hold monthly video conference tumor boards with them through computer Skyping and audio, and these have turned out to be very popular and very much appreciated by their staff. They usually have 70 people in the room listening to the description of the cases and discussions of management. We now have much more accurate clinical subtyping due to the fact that they're able to do some IHC and they share their cases with us. And so the treatment now will, I think, become more routine and more specific for the type of disease, specifically the separation between the aggressive lymphomas, non-Hodgkin's lymphomas, and Hodgkin's disease. And finally, over the period of this grant, we've been able to procure Rituxan, which is an anti-B-cell antibody that's critical to the improvement in treatment for non-Hodgkin's lymphomas. And so it is available most of the time. It's not always available for these patients. So this is a slide that just shows some of the issues in the larger picture of treating cancer in Africa and sub-Saharan Africa. And many of the patients don't even survive with cancer. The ones we're seeing are all ones that come to the hospital. Many of them don't survive to actually have accurate diagnosis and even the beginnings of treatment. There is a mean of 2 years from the onset of symptoms in these patients to their visit to the clinic, and 20 months from the initial primary clinic visit to treatment. So there's a lot of delay involved in getting the accurate diagnosis and instituting treatment. Most of the patients, for example, with breast cancer, present with very advanced disease, and it's really transitioned to a fatal disease from a potentially curable disease at that point. And the impact of this stage migration is that we estimate that probably half the deaths from cancer could be cured by just reducing the time to initiation of treatment. I just want to enumerate some of the initial benefits of our partnership, because I think this is very important. It was one of the questions that arose. What would happen if the foundation invested in this? Would it make a difference? I mean, obviously, a lymphoma population of 100 patients a year is not making a great impact on the world, but a number of things have happened because of this. There was a first National Cancer Congress a conference held there in 2014 to institute a national plan for cancer control. A second conference was held this fall, and our institution plus Penn, Baylor, oncology groups from those places participated, and a plan is now in effect to address some of the issues about referral, diagnosis, and adequate treatment. We've been able to obtain a total of 4 grants related to this work, and they're shown here, 3 from the National Cancer Institute. And there have been multiple training and teaching exchanges as a result of this, and a fund has been set up to support the travel, which is crucial. And then there are a number of future challenges, and I think I've mentioned most of them: training, expediting referral, cancer education, improving access to treatment. I should mention one thing. We all value innovation. There's a very innovative technique for local diagnosis that is going to be evaluated there. The V Foundation is supporting this, and it's a device that can be coupled to a cell phone, and it depends on aspirating from a mass or lymph node and then injecting into the cell phone, and then using antibodies in the chamber. The reaction of the antibodies to any cancer cells in the solution is then transmitted electronically to the server, and we get back a reading about cancer is present, cancer is not present. And this is being prototyped at the MGH. It's gone through a number of testing there, and it seems to work, and it's going to transition to this site as a test in the next couple of years. And this is a group of people that gathered at the latest conference, and you can see there are a number of our folks here in the front lines, but a very willing group of great people from Botswana now involved. And so thank you very much. I'll be happy to take questions.
I have a comment and a question. So you made a point of emphasizing the pathology of Burkitt lymphoma. I thought you were going to point out and say the classic textbook description is starry night.
Yeah. Starry sky.
Starry sky, but close enough. We had the
Starry Night's the painting.
Yeah, but it's close enough. So we got an opportunity to see that. Do you think that better control of HIV would be the simple solution for decreasing lymphoma?
Yes. Very good question. In fact, there's a grant that's going in now to look at the fact that these patients are often treated for HIV. The several years after the onset of the infection. And the longer you delay, the more the immune compromise, and probably the greater the opportunity for viral proliferation and transformation. So we think that's a major factor in the sense that in the U.S. with early institution of antiretroviral therapy, we're seeing a marked decline in the incidence of cancer. There, it hasn't had the same impact.